Hi, I'm Marc Koska. I'm delighted to welcome you to this series of videos that are going to look at innovation, manufacturing, and how we can help develop the world of safer and more accessible injections for all. This is going to be a very interesting series using people inside and outside the ApiJect group, and I'm sure you're going to enjoy these conversations.
Probably at this point quite a significant probability of being a very major game changer for the whole business of injection.
How are you?
I'm good.
Good. Who are you? Tell us who you are.
Oh, I hate to talk about myself, but
Since when?
Yeah. Right. I'm someone who's strangely been in the business of non-profits in global health for 50 years.
What does that mean, non-profits in global health?
Yes, it means that I never make any money.
I must be in that game as well.
But it means, I'm working for non-government organizations that back in the 70s were not regarded very highly by public or private organizations, and therefore sort of attempted to do something that was that needed to be done
Just to stop you a minute, so we had the UN, right?
Yes.
And the UN obviously had a health division.
Yeah.
Why do we need extra non-governmental?
Well, the UN doesn't develop technologies or products that are needed, for resource for specialized populations in, say, resource.
And it was never imagined that it would have an innovation department?
No, it was never imagined, and they felt that they had to rely on what serendipitously developed in industry and then try to get it adapted or made available at appropriate, affordable prices.
And of course, industry essentially doesn't want change because it costs money. If they've got an existing market, they'll just carry on.
Right.
Okay, so you're the sector that you helped develop basically played the middle ground between industry and the authority.
It did. Yes, it was in between industry and the public sector. But oddly, of course, the public sector itself became very suspicious of these middle people like us, and we were perhaps very few at that time, because we were doing technologies, and so they couldn't imagine anybody doing technologies that weren't profitable. Weren't seeking profit.
Yeah.
And so for many years, a decade or so, we were in their industrial files. They were dealing with us as if we were an industry. And we had to then go through all the machinations to try to convince them that, in fact, no, we weren't seeking any return on this investment, only social impact.
That's hard.
Tough, yeah.
And we're do-gooders. Right. Oh, yeah, sure you are. Yeah.
And so it did take a long time to convince them. They did eventually come along and say, clearly, we were doing something very useful, and we had some impacts, very early impacts. And in fact, I think to some extent we ultimately shifted the public sector organizations to thinking quite differently about collaborating even with industry, because now, in fact, non-profits like we started back in the late 70s are having a difficult time because the industry is in fact collaborating with these same organizations and be much more willing to get involved with solving problems.
It's a cycle, I guess.
It's a cycle, or to some extent, I suppose we also help to make that change,
by being successful and feeding innovation
that's right.
into
and also, since also what we developed was found its way into industry and became, if not a major profit center,
mainstream,
became at least profitable.
Yeah.
And even we had to adapt to the notion that if you're going to make something that's really going to get to where it's needed, it's going to have to be made commercially and have a reasonable return on investment to scale to where you want it to scale. And
So you were born where?
I was born in Devon.
Devon's a fantastic county, I hear.
It is lovely. I think you should go and live there.
Yes, I'll think about it. To the viewers, I do live in Devon. And where do you live now?
I live now in a little island off of the coast of Washington State in the United States.
Up near Seattle.
Near Seattle, yeah.
So you're surrounded by orcas and whales,
Indeed,
no doubt.
yes.
Yeah.
Mm-hmm.
Okay. And, so obviously I know the story because we've known each other, 30, 40 years. So you're in Seattle because of the organization PATH.
The organization that I helped to start, yes.
Yeah. PATH was started what year?
77. So we worked across a large span of problems, including, vaccine delivery and even diagnostics and technologies for reproductive health and so on. But in the 80s, one of our main activities was for safe injection. We were prompted very early on by WHO to help them solve the problem of needles being reused in poor countries, and they were worried, in fact, that they were causing more disease than they were actually, preventing with vaccines, because of hepatitis B, hepatitis C, AIDS, even Ebola. Transferred in dirty needles.
That's right. And a lovely Greek-derived word, iatrogenic, which means caused by treatment.
Yes, exactly that.
And a little-known word, but obviously it's a huge problem. If you can, it destroys trust, it spreads more disease than you're trying to cure, it costs an enormous amount of social capital and financial capital to solve the subsequent results of iatrogenic transmission. The thing that I'm always trying to get across to, people who are interested in this topic is a product called Uniject.
Right.
And Uniject is what I believe we're sort of treading on the shoulders of Uniject, because Uniject brought in a new technology or a new format for giving injections and delivering safely drugs, which to me carried and created an incredible amount of hope that a change could come and a change could be implemented across most of the developing world for lots of good reasons. Was that the same feeling for you? Was that sort of a height of hope when you were working on Uniject?
Well, absolutely. And also a character called John Lloyd, a wonderful sort of visionary character, sort of had this far-flung vision that one day there would be a device that actually was pre-filled, single dose, auto-disable, and could be put in the hands of all people getting vaccines then.
Let's just unpack those things. So pre-filled, why would that be an advantage?
Because it would lessen the skills required to actually deliver an accurate dose, a safe dose.
It's filled on a machine robotically with exactly the right amount of drug per person.
Yes,
okay. Yeah. You said auto-disable, which means?
It can only be used once. There's no way you can actually refill it in the field and reuse it.
So a guaranteed single use. Yes, so it's sterile every single time. Yeah. Compact, is that a key here?
Very necessary, although inevitably it's going to be more shipping volume than regular syringes. So that was a trade-off that had to be dealt with.
That's because a lot of the drugs or vaccines that are delivered need to be kept at fridge temperature.
Correct, and they're in 10 dose vials, which is it's very hard to match the volume of 10 dose vials if you're adding a syringe to each dose. So.
Right. So 10 dose vials are more compact than single dose vials. So what we're imagining with Uniject is a single dose, so it's taking up a relatively more or precious space in this cold chain, which takes money and energy to run.
That's right.
To create in the first place and then maintain and run.
So our notion was this was future scoping. We didn't imagine that this was going to impact in the near future. at that point in time. We felt, this should be developed and it will find its way inevitably toward.
Because it's so obvious.
Yeah, yes.
John worked for you, or you worked for John at this
John,
time?
at that time, worked for WHO Extended Program on Immunization,
Okay.
but eventually we hired him.
Okay, and so what did the day look like? What did a Monday morning look like when you were trying to sort of look at the nascent form of this compact, pre-filled, wonder machine?
It looked like an extension of Sunday's workday.
Well, knowing you, that would be mowing the lawn or trimming a tree or something.
Back then, it was back in the lab. Yeah.
So prototype,
exactly.
a bit like we do here.
That's right. Iteration after iteration, and then also trying to find a first level commercial organization to make products for field trials.
So your sort of mission was to discover, fine-tune, and bring to reality the technology,
right,
and the materials and everything else, and then present that as a finished format to a manufacturer and say, job done.
We couldn't convince the manufacturer at this stage, so we essentially had to...
Because no market.
No market.
Right.
We had to essentially, if you like, hire or find some manufacturer who was willing to collaborate on some basis in order to make products for clinical trials. And it was necessary in those days to have very significant and profound amount of clinical trial data to convince the gatekeepers of public health in developing world to even take a look at this device. There's a lot of friction in the whole process.
Sure. Well, I mean, look, my story because I was in syringes and from mid-'80s onwards, and for me, I was standing on the shoulders of all the syringes that had come before me. So, there's an advantage, there's another advantage, there's another advantage. And so but I was standing on, 100 years of technology, whereas what you were doing was standing on nothing because no one had ever imagined this before.
Right.
I was Surette in the Second World War. Yes, it was sort of an early form.
That would be, you'd have to point to that to the very, very first notion of having a squeezable tube with a needle on it.
Yeah, which is like a toothpaste tube with a needle.
Yeah.
You squeeze the toothpaste tube, that injects, And that was for emergency.
Soldiers carry them for morphine, for wounded.
Okay, so I want to really go back to the hope factor. So we've described the features. Why would the world benefit from that? What was wrong with syringes and glass vials?
It solved many more problems for people trying to convince countries and vaccinators to actually deliver the vaccines to where they're needed. It essentially did away with the whole business of having to measure out an exact dose, do it safely, and then deliver that dose, accurately. So it essentially eliminated a whole bunch of risks associated with delivering vaccines.
Okay, so those are the benefits, but what was the palpable state that you were seeing at that time? Were you seeing unexplained deaths? Were you seeing an outbreak that shouldn't have occurred because it was in the wrong territory for maybe the zoonotic transmission? What were you seeing that was leading you to need solutions?
Actually, no, it was in the context of all of these reused syringes. It was in the same context as auto-disable syringes, because, as you know, we were working on that at the same time. So, it was the context. It was a future scoping context of that activity, and it was maybe it was even dreaming of a blow-fill seal, second generation of Uniject 2, which could solve the next level of problems, which were the Uniject being too expensive and too slow and too capital intensive, and a number of other issues, which including monopoly supply, which has severely restricted the use of Uniject over the years.
Right. Well, I mean, jumping forward to what we saw with COVID, there was an incredible lack of supply and confusion in the logistics of getting glass, for example, to be filled in the right places. There were stories of, volumes of donated COVID vaccines sitting on runways because no one wanted to pick them up in a developing world country and take them to a filling line and put them into individual vials because they didn't have a filling line. Where were they going to take it? So, I mean, that really did shine a spotlight on what you're talking about is, were you that... to deliver that, would you be forced to reuse a syringe a number of times, or would you? And of course, it's no one's fault if there isn't a product. You're just going to do the best, make the best decisions that you think of at the time. So, I think that anyone watching this would know kind of what we're doing, but it's a really interesting background that you've supplied so far to explain our raison d'etre, why we're here. And of course, what I did was think, well, I wonder whether there's a modern way of meeting this hope. Is there a better technology that's evolved since that formation of Uniject or creation of Uniject? Is there, what have I learned from the syringe business that could be put into the pre-filled syringe business? And of course, that's what ApiJect was based on. But I still revel and sort of, if we're coming to the end of the last few minutes of this talk, I still really revel and put on a pedestal the hope and the promise that a pre-filled, auto-disabled compact design might bring to the marketplace. So the current status of where we are with, this is one of our latest designs that we've just made, and you've seen it and used a couple on mannequins. What do you think the hope is for ApiJect in its current state?
Well, I think it's crossed some very significant thresholds of from possibility to probability. Probably at this point, quite a significant probability of being a very major game changer for the whole business of injection. I could see it, interestingly, also being a leader, finding its way into the developing world faster than the developed world. But that then it would, I think, become a very rapid inducer of uptake of this technology. And it ultimately becoming a major option for people buying any type of pre-fill.
And pre-fill isn't everything, because obviously with intravenous injections, they have to be measured for each person. So syringes still have a very valuable place.
Of course.
But yeah, I think, just to add a bit more color, this is really good when you've got a sort of a campaign situation where you're delivering the same dose to a lot of people. This is a great advantage for that, because you're not titrating every time. You've got consistency. It's very light, it's robust, it's easy to use, etc., and very low cost as well.
Yeah, but I see equal value for it for routine injections, including, for example, obstetric emergencies, where oxytocin may be called for postpartum hemorrhage, and probably in a number of other injections, as well as the whole range of single-dose vaccine delivery. Putting this in the hands of health workers, I think, would save them time. It would save them. It would reduce their risks. Right now, if you think about it, all the risk is put on the vaccinator or the injector, the person doing the injection. They have to carry the burden of all the risk, and the sort of conditions that they're giving that injection wouldn't be allowed in developed world countries.
Yeah, that's because there are multiple stages, and each stage could go wrong or could be misinterpreted by someone, and therefore they're doing something that could harm the patient.
They're doing a multi-dose vial which could get contaminated. They have to keep it.
Well, thank you. I mean, we agree that this solves an enormous amount of the procedural issues, it solves a lot of the logistics issues, but also we believe that this is a great advantage for manufacturers as well, because it's, you push the button and this starts making product, and we're making 10 every 3 seconds.
Game changing.
And it's very economical, and it's a great advantage, hopefully, for every sector involved in delivering safety.
Right.
Okay. Well, to wrap up, any final comments, or should we go to the pub?
I'm waiting for the next stage, but meanwhile we can talk about that other pub.
Great. Thank you, Michael.
Yes.